Hi all, welcome back. The last topic in the muscle tissue lecture is cardiac muscle. And we're going to talk about cardiac muscle, and then we're going to talk a little bit about a few other things, how muscles work, kind of shapes of muscle and that kind of stuff, which will determine kind of the name that the muscle gets. But cardiac muscle, this will start us off. So as it seems by the name, cardiac is located in the heart. It's a striated muscle cell, just like skeletal muscle, right? But it also has a specialized structure which will allow you to tell whether you're dealing with skeletal muscle or cardiac muscle, and that's intercalated discs. These discs are what join muscle fibers together. And these discs are what allows for a impulse or a contraction to move from one fiber to the next. And so that really allows for the kind of wave impulse to occur on these muscles. Okay? They contain a single nuclei, and then the network of fibers contract as a unit or a syntidium. Okay? They are self-exciting, so you don't have a choice. Um, they're rhythmic, so they have a pattern, as you would expect. They do have a longer refractory period than skeletal muscle, and they are a muscle that doesn't really fatigue. So they can sustain for a very long period of time, but not from a summation perspective. Okay, so there's an example of intercalated discs that attach cells together. So they occur between the cells, but allow for the impulse to move from one cell to the next. Pretty much undisrupted, and so that's very needed in order to do that rhythmic pattern. You have to have a wave of contractions occur so that you don't have a latent period where one cell's not firing. So all of them are firing kind of not simultaneously, but one after another. So if we look at muscle tissue in general, we can look at the differences here. So skeletal muscle, so up to about 30 centimeters. This is by far the longest material. Remember, they have multinucleus in each one of their cells, so that allows them to be much longer. Because they have multiple command centers. Smooth muscle and cardiac muscle tend to be shorter. They can be roughly the same length, or at least same range. Diameter, again, skeletal muscle is larger for the most part, with smooth muscle being the smallest, and then cardiac muscle can be about the same size as certain skeletal muscles, but never reaching the maximum. Okay, major location, of course, we know that skeletal muscles are everywhere. Smooth muscle is typically your organs, okay, and cardiac muscle is associated with your heart. Okay, major functions, we already know these kind of things. Striations, they're present in both cardiac and skeletal, but not in smooth. Okay, multinucleated in skeletal, but not in smooth and cardiac. Okay, transverse tubules are well developed. Remember, these are the tubules that send the signal to the sarcoplasmic reticulum from the nerve. So that's why they're well developed, because you consciously can fire these, where there's no conscious firing of here, so they're not needed. They are well developed here, but they're well developed because they connect the intercalated discs, and so that's really why they're well developed here. So they fire the AV node, or the impulse is fired between cells. So it's just a way that you can continuously have a rhythm here. Again, we already talked about this: voluntary, involuntary. Contracts and relax relatively rapidly. That's skeletal muscle. Okay, contracts and relaxes relatively slow compared to, especially when you're comparing to skeletal. And sometimes it can self-excite. Okay, so again, if there's a stretching motion, sometimes that'll cause the muscles nearby to form kind of a rhythm. And in the case of cardiac, they are self-exciting in all cases. They're rhythmic, okay, and just in general, they're unique to the heart, so they have a lot of unique features, and we'll talk more about the cardiac system later, but just realize that their muscle cells are unique. Okay, body movement. Normally we're talking about skeletal muscles here, and so we're talking about how bones and muscles come together and how they kind of form a lever. And so you have a rigid bar or rod, which we would know as the bone. Okay, you have a fulcrum or a pivot point, which we know as the joint. Okay, and then you have an object that you're going to move against, which is weight, and then you have a force that supplies the energy for that movement, which is the muscle. Okay, so that's kind of how we can think of as our body movements being components of a lever. So if you've taken physics, these are all components of a lever, both, the rod, the fulcrum, the resistance, and the force. Okay, and our body does the same thing. So we can look at examples of this, and I'll show you some photos or diagrams of this. But when you're bending or moving, especially things like your arms and legs, this is kind of how the fulcrum or lever system works. Okay, so during the bending, the forearm bone acts as a rigid bar. Okay, the elbow acts as the fulcrum, and then the hand against something is going to provide the resistance, and then of course the muscle that is going to be attached to the forearm is going to provide the force needed to move it, or not move it. Depends on how much resistance there is, because remember, in some cases, when the resistance is higher than the force, or is greater than the force, you have an eccentric reaction or eccentric reaction. Okay, so just looking at this, so here's your resistance, so say 10 kilograms. Okay, there's a force being pulled by the bicep. Okay, the bicep is attached at different points, attachment points, and we'll come back and talk about this in a little bit. But the joint here, okay, the elbow joint, is going to act as the fulcrum, or the point at which the two bones are attached, or the two rods are attached, and the point of movement, or the point of connection. Okay, so pulling this way, going up, remember that's a concentric force, and eccentric force is going the opposite way. Okay, but only in the bicep. Okay, the tricep is contracting, so that's concentric. So you often will have a flexing and extension of the elbow, and so you have both muscles working opposite of each other. One muscle being concentric and the other one being eccentric as you move the object. Okay? A little bit more about origin and insertion. Okay? One end of the skeletal muscle is more fixed. Okay, and then the other end tends to be more movable. Okay? How movable depends obviously what part of the skeletal muscle it is. So the origin is the less movable end, the insertion is the more movable end. Okay? So you have an origin of the bicep, okay, up near the coracoid process. Okay, and that is going to be less movable. Okay, and then the bicep is both a long end and a short end, or a long head and a short head, but that's going to have an insertion, okay, on the radius, and that's going to be more movable. So less movable, the origin, more movable, the insertion. Okay. When you're contracting a muscle, the insertion end is pulled towards the origin end. Okay? When the muscle is relaxing, okay, the insertion moves away from the origin. Okay? And it gets a lot more complex than that because a lot of muscles will have multiple origins and multiple insertions, or maybe just multiple origins and one insertion. It just depends in many cases. In this case, you can see it has two origins, okay, and a single insertion. Now, when we're talking about muscles in general and the naming of muscles, a lot of times the name of the muscle is also associated with, well, what does that muscle look like? What's the actual shape of the muscle? Okay, is it fusiform, or what some people like to call like football shaped? Okay, so it's pointed at each end, but it's kind of got a belly in the middle. Okay, is it parallel? Is it equal? Okay, is it triangular, unipinnate? Okay, so it's shaped kind of like the pinnate or unipinnate means that you typically have lots of projections that are coming up, but in this case, in the case it's single, okay, off of one tendon. And they're all coming off the same tendon. Bipinnate means you have a tendon and it comes off both ends, okay, or both sides of the tendon, the fibers do. And then multipinnate, okay, something like the deltoid, it's going to have multiple tendons coming through, and it's just going to be pinnate off of that, okay. So, and then there are some very specialized, like the opercularis oculi, which is circular. And so depending on the region, depending on the function, you can have these different types of muscles, and sometimes their name is directly related to the shape, and other times they're just related to the bone that they might be attached to or the region that they occur. And so that's kind of how muscles can look, I guess, classify them. Yeah. Now, again, back to the synergistic or antagonistic muscle pairs. Remember that muscles are going to be in line with each other, so you're going to have a flexor and an extensor. So when the flexor is contracting, the extensor is relaxing, and vice versa. So muscles are paired up in a way that one muscle will flex or contract while the other one relaxes, and then vice versa in the opposite kind of motion would be vice versa. So here they're showing you the biceps brachii is the flexor, okay? And the triceps brachii is the extensor. So it's elongating while this one is contracting. So this one's relaxing, this one's contracting. This one relaxes, this one's contracting. Okay. Let's talk a little bit about situations, injuries that might occur due to muscles. And we'll come back and we'll look at a bunch of these at a later date. Okay. But hernias are one of the injuries that often occurs, and that is directly associated with the muscular wall. Okay? And so a hernia is when the viscera protrudes out a weak part of the muscular wall. Okay? And it can happen in a few different regions, but you have muscle that's covering your viscera, the inside portion of your body. Okay? And when that muscle kind of gets separated, you can have that viscera kind of protrude. It can stick out and create a hernia. And there's a couple different types of hernias that can occur, and their types occur based on where they're kind of located. So you have an inguinal hernia, which is going to be the viscera, the inguinal canal, or in the region of the scrotum. Okay? It is by far the most common type of hernia because it occurs in regions where the muscle is easily separated, often by injury. And so then you have a hiatal hernia. This is where the stomach is going to protrude through the diaphragm. Okay. Can be very dangerous. The older people get, the heavier people get, will often increase the likelihood of a hiatal hernia. And then an umbilical hernia also can be the result. Both inguinal and umbilical are often the result of injury to the muscle in that region, and can be due to things like weightlifting and things like that. You often get, or strenuous activity, you can often get one of these two. But the umbilical is when the viscera protrudes through the navel area. Okay? So let's kind of look at what this would look like. Okay, so let's say you have a ventral abdominal hernia. Okay, so you can see the intestine here is pushing out, okay, creating a bulbous, a bump here, and that means it's pushed through the muscle. Okay, so if we opened it up, okay, which a doctor would do to fix this, if you take and you open up the outer epidermis, you're going to see that the muscle has been separated. The rectus abdominal muscle has been separated, and that in this case, the intestine is pushing through. Okay, so probably what would occur is you cut the epidermis and then you push the intestine back in, okay, and then put a mesh that is sewn between the two muscles to provide some strength so it doesn't just pop back out. Okay, and so you kind of put a mesh in there and then suture the epidermis back, and then over time that wound would heal completely. Not a terrible surgery. Happens often, but just an example of when you have a kind of connection between the muscle, the epidermis, and even the viscera, the insides, and how that could be corrected. Let's look at another one. So carpal tunnel syndrome often occurs in individuals that have continuous movement or repetitive movement within their hands on a long period of time. And so carpal tunnel is related to the flexor reticulum. Okay, so it's a fibrous sheet. Okay, that kind of it crosses over the wrist. And so you have tendons that run underneath that, flexor tendons that run underneath that flexor reticulum. And that space is called the carpal tunnel. So where the carpal bones run underneath the flexor reticulum, that space is called the carpal tunnel. And so people call it a carpal tunnel syndrome when that space becomes extra tight or inflamed or pushes on the nerve in that region. So if we kind of look at that, I'll show you some examples, some pictures of this. So that flexor tendon passing through the tunnel, okay, is enclosed and it's it's enclosed in a tendon sheath, okay, and sometimes you can get that tendon sheath moving back and forth. Sometimes you can get a little fluid buildup in there. You can get inflammation. Okay, you can get extra blood flowing in there. And if it gets overworked, okay, then you can get the tendon building up. Okay, so if you look at this, so that's these tendons of the flexor digitum. Okay, they're moving. So individuals that are moving their fingers a lot, typing, writing, clicking the same button over and over, holding things in your hand, always lots of things. Individuals that do the same motion over and over and over again, these tendons tend to keep stretching back and forth, moving back and forth, back and forth. And eventually it gets inflamed. Okay, and you can get these ligaments can start to push down on the median nerve. Okay? And then that's where the pain comes in. That's where the discomfort comes in. Okay? If it's bad enough, what'll happen is they'll just do a little incision, okay, and they'll cut the transverse carpal ligament. And that will release the median nerve and the pain will go away. The problem with doing that, though, is that ligament's needed for grip. And so individuals who have this surgery done, they'll often have a much weaker grip, but they won't have pain. We'll talk about other things that are associated with muscles and kind of ligaments and tendons that are associated with that at a later date.